Hey, welcome to the Memorizing Pharmacology podcast. I'm Tony Guerra, pharmacology professor and author of the Memorizing Pharmacology and Memorizing Pharmacology Mnemonics series of books. What we're going to do today is go over the critical thinking activities in chapter 1 of this Nursing Pharmacology OER book. That is, it's an open educational resource, so you can get it for free if you like. And we're just going to go over the critical thinking activities in the first chapter. So we're going to be not skipping around as much as we're just going to kind of zero in on those activities that really focus on critical thinking. And then if you want more information, you can always go back to the book itself to check it out. So the way it works is we're just going to go here and we see, okay, critical thinking activity 1.5a. Metabolism can be influenced by many factors within the body. If a patient has liver damage, the patient may not be able to break down or metabolize medications as efficiently. Dosages are calculated according to the liver's ability to metabolize and the kidney's ability to excrete. When caring for a patient with cirrhosis, how does this condition impact the doses prescribed for the patient? So when we have somebody that has cirrhosis, the first thing we're really kind of saying is that the liver is damaged, right? So if these transformations, or biotransformations as we call them, are in the liver and normally are taken care of by liver enzymes, and those liver enzymes are damaged and so forth, then they're not going to work as well. So what happens? Well, we really want to talk about here where if you have less and if you have more ability to metabolize these medications. So let's think about it this way. The liver can normally metabolize some amount of medication, right? If it's damaged, it's going to be like when you're at work and there's one less person there and you can't get things done as quickly. So for example, it's very often that, you're in a restaurant and they'll tell you, hey, we just don't have enough waiters tonight. Sorry, times are a little bit slow. Okay. All right. So your food isn't going to get there as quickly. When we're talking about metabolism and medications, that means that we're going to have more or less medication hanging around. Well, if the liver's job is to break down the medication, then that means we're actually going to have more medication sticking around, okay? And that means that we need to do what with the dosage, okay? The dosage needs to go down because the amount of medicine still in the body, because the liver can't break it down, is going up, okay? So we're basically lowering dosages to decrease that toxicity, okay? So again, as we go through these critical thinking activities, you can kind of stop the recording, say, okay, well, let me try to answer it, and then kind of go from there. Okay. So we're in now excretion. So if we're thinking about pharmacokinetics, we have absorption, distribution, metabolism, and excretion. The liver is the organ that is most associated with the breakdown of medications or transformation of medications and metabolism. But when it comes to excretion, we're talking about now how good is the kidney function. Okay? So when providing care for a patient who has chronic kidney disease, how does this disease impact medication excretion? Okay. Well, if many of these medications and metabolites, the kidney filters them. When we are not able to get rid of them, okay, we might find that we are now getting resorbed back into the bloodstream. The kidneys aren't working. They're just kind of hanging around, and we have a very similar effect to the liver. But just to be clear, the liver hasn't been able to break it down, and we keep more medication around. With chronic kidney disease, the medication excretion, okay, is going to be slowed down because we just can't get rid of it. The kidney's damaged. Okay. All right, let's go on to the next one. Pharmacodynamics. So we have pharmacokinetics and pharmacodynamics. Pharmacokinetics is really the absorption, distribution, metabolism, and excretion. Pharmacodynamics, now we're going to talk a little bit about how a medication and its effects are going to create a need for an assessment or different type of assessment. So the question is, atenolol, tenormin, is a beta-1 antagonist, right? With a negative inotropic and chronotropic effect, okay? What should a nurse assess before administration? Well, let's start by defining that word inotropic, okay? Inotropes are generally going to increase or decrease the strength of contraction of the heart, whether it's a positive inotrope where it increases the strength of contraction or a negative inotrope where it reduces the strength of contraction. So digoxin is a positive inotrope. Other ones include dopamine, dobutamine, adrenaline, noradrenaline. Those are positive inotropes increasing the strength of contraction. Negative inotropes include like amiodarone, amlodipine, carvedilol, metoprolol, propranolol, ramipril, valsartan, those types of things. So when we're talking about these medications, we are looking and saying, okay, we have a beta blocker. This is a negative inotrope. This is going to reduce the force of contraction, okay? But what's it going to do as far as its chronotropic effect? So again, we want to define, well, what is a chronotropic effect? So a positive chronotrope is one that's going to increase heart rate, get you closer to tachycardic. And then a negative chronotrope is one that's going to reduce heart rate. It's going to get you closer to bradycardic. And again, to define that, bradycardia is, right, 60 beats per minute. Tachycardia is 100 beats per minute. So to give you some examples, if we talk about the positive chronotropes, we would think like atropine, dopamine, dobutamine, epinephrine. If we think about the negative chronotropes, we're talking about digoxin, diltiazem, verapamil, metoprolol. But really, we could say beta blockers in general. So it's important that we see that atenolol has negative inotropic and chronotropic effect. So what should the nurse assess before administration, now that we know what these are for? Okay. Well, it's reasonable that if you've got something that's going to reduce heart rate and maybe reduce heart blood pressure, then the first thing that we want to do is we want to assess the patient's pulse and blood pressure and make sure that they're normal. What we don't want to do is have somebody that maybe is already bradycardic and bring them even down lower. Okay, now I run marathons or I run long distance, so my normal heart rate is probably in the 50s. So they would just check, okay, well, that's normal, that's fine, it's not that something is happening. Okay, but that's what we would do. All right, let's go on to 1.9. We have two parts to this one. First, number one, at 0500, your patient who had a total knee replacement yesterday rates his pain while walking as 7 out of 10. Physical therapy is scheduled at 9. Patient, 0900. Okay, so 9 a.m. to us. The patient has acetaminophen, Tylenol, 625 milligrams ordered every 4 hours as needed for discomfort. What should you consider in relation to the administration and timing of the patient's pain medication? So there are really three things that we're going to do here. First, we have 0500. Okay, that's what time it is now. Okay, the patient needs medication. We'll give them medication now. Right? We know they're going to need it in about 4 hours. So what we can do is after about an hour, check with the patient, see how they're doing, see if their pain has improved. Then just before the physical therapy session, we want to make sure that they get their medication because we don't want them to have one dose at 5, then 4 hours later start their physical therapy session and be in pain while that's happening. So we want to make sure it's a little ahead of time. The last thing we want to do is we want to make sure that we don't exceed the maximum Tylenol for the day. And there's a couple of numbers here. generally, we say that we really don't want to be above 4,000. But if you actually talk to the makers of Tylenol, they would prefer that number be even closer to 3,000, a much safer amount. If the patient, and this isn't in the paragraph, but if there were some alcohol disorder or patient is a drinker, we would want to reduce that Tylenol even more because we want to be careful with the liver. So 0500 patient had a total knee replacement yesterday. Pain walking is 7 out of 10. Physical therapy is scheduled at 9. We give the first dose at 5. Then we check with them about an hour later, make sure that it's working. Then just before the physical therapy, we give them another dose. Okay. Then 4 hours after that, they'll get another one. And what we're making sure is throughout the day that the patient isn't going over the amount they should have. Now we can do a quick calculation here. If 625 is ordered every 4 hours, let's see what that total would be. And I know what it is. I can do it in my head, but I'm just saying let's get the Google calculator out. Okay, so the first thing we want to do is we want to be careful. We don't multiply the 625 times 4 because it's every 4 hours. We would multiply the 625 times 6. And we see that that number, 3,750 milligrams, is right there between 3,000 and 4,000. And what we want to make sure is that, okay, maybe it's around the clock, but maybe it's not, because this isn't for inflammation. Tylenol doesn't, acetaminophen doesn't help with inflammation. If the patient can sleep through the night, then okay, maybe one of those doses we won't use and we'll get a lot closer to that 3,000 number. Or maybe it'll go out a little bit further, closer to the 5-hour mark, something like that, and we get down to 3,000. But we're really hovering on the edge. So this is where we really want to be careful. If someone says, okay, well, the pain isn't being taken care of, let's add some Vicodin or something like that. And Vicodin in it, or Vicoprofen, would have an additional, or Vicodin, not Vicoprofen, Vicodin would have an additional amount of acetaminophen. So we definitely want to be careful of that. Okay. All right, well, let's look at the second one here. Number 2, your patient is prescribed NPH insulin to be given at breakfast and supper. As a student nurse, you know that insulin is used to decrease blood levels in patients with diabetes mellitus. During a report, you hear that this patient has been ill with GI upset during the night, and the nursing assistant just informed you he refused this breakfast tray. While reviewing this medication order, you consider the purpose of the medication and information related to the medication onset, peak, and duration. Again, we're talking about the NPH insulin right now. When reviewing the drug reference, you find that NPH insulin has an onset of about 1 to 3 hours after medication administration. What should you consider in relation to the administration and timing of the patient's insulin? So let's take a minute to think about it. All right, so you're back, and let's think about this. So the insulin is supposed to decrease blood sugar levels, but the patient's stomach's been hurting quite a bit, and he's just not hungry. Well, wait a minute. Insulin can be used to reduce blood glucose levels, but our expectation is that glucose levels are going to be increased each time the patient eats. If the patient is not eating, well, then we need to really make sure that we're not going to cause hypoglycemia. So again, hyperglycemia is glucose that is too high in the bloodstream. Hypoglycemia is when it's too low. So insulin is one of those high alert medications. And so if this continues to happen, the patient keeps refusing the food, but keeps getting the insulin, we could be in a lot of trouble. So we want to make sure that we work with the patient, make sure that we're checking if they're eating, and make sure that the insulin dose is appropriate for how much they're eating. And we would do that by doing some blood glucose tests throughout the day to make sure that those blood glucose and blood sugar levels are where we want them to be. All right, here is critical thinking activity 1.10a. Mr. Parker has been receiving gentamicin 80 milligrams. This is under medication safety. Has been receiving gentamicin 80 milligrams IV 3 times daily to treat his infective endocarditis. He has his gentamicin level checked 1 hour after the end of his previous gentamicin infusion was completed. the result is 30 micrograms per ml. Based on the results in the above patient scenario, what action will the nurse take based on the result of the gentamicin level of 30 micrograms per ml? Okay, so I'll give you a minute. All right. The normal lab value, okay, that's kind of the first thing that we have to do. Okay, it's like 5 to 10 mcgs or micrograms per ml, right? Or if you're using micromoles, it's like 10 to 20, a little higher, okay, per liter. What we can do is see if this patient has good kidney function. There might be some kind of renal impairment that is not helping with excretion, and we need to make sure that we adjust the dose on the next time. So again, we've got a result. We compare the result to the normal gentamicin levels. We see that the level is high, and now we're going to check maybe kidney function, what's going on, because gentamicin itself is ototoxic, damaging to the ears, but also nephrotoxic and can actually damage the kidney itself. Okay. All right. I'm actually going to stop it there before we go to 1.12 module learning activities. I think that, that 15 minutes or somewhere between 15 and 20 minutes is a good amount of time. So again, you can go to the Nursing Pharmacology book, and we went through 1.5 metabolism, 1.6 excretion, 1.7 pharmacodynamics, 1.9, okay, we're examining the effect, 1.10 medication safety. Okay. So again, if you want to check out a course on pharmacology that has all those mnemonics and things like that, you're welcome to check out the self-paced pharmacology course with mobile quizzes and videos at residency.teachable.com/p/mobile. And you can always get half off, HALFOFF. Again, it's HALFOFF to get half off.